Cri-du-Chat syndrome is very rare, but it's worth talking about because it is not very rare to come up on the test. It has some very characteristic features that aren't seen in other illnesses. So this is a favorite of the USMLE just to make sure that you're on your game. All right, so this is a neurodevelopmental condition, and the characteristic feature is this high-pitched cry that happens during infancy. And so a lot of times the obstetrician will notice this when the baby cries, it actually sounds like a kitten. And it's also sort of monotonous. So if you listen to a regular baby cry and then you listen to one of these babies with Cri-du-Chat syndrome cry, you'll notice a very, very striking difference. And this is caused not only from laryngomalacia, which certainly is going to cause a high-pitched cry, but it's also seen in babies who don't have laryngomalacia. And so there's thoughts that abnormalities of the brain can be contributing to this as well. One of the interesting things about Cri-du-Chat syndrome, and really, I mean, we see it in a lot of genetic syndromes, but the manifestations and the features change over time. A lot of times, these babies are generally very hypotonic at birth, but this changes and even goes to the other side where children with Cri-du-Chat syndrome are rather hypertonic. Like I said, this is pretty rare. It's about 1 in 50,000 live births. There's a slight female preponderance. So it's like 5 to 4 females to males, but we don't really know why that is. But for the most part, you're going to see these in both genders. The cause of Cri-du-Chat syndrome is a complete or partial deletion of chromosome 5. So a lot of times you'll hear this referred to as 5p minus syndrome or 5p deletion syndrome. It can be part of the chromosome, it doesn't take very much, or it can be the entire short arm of chromosome 5. And the severity of symptoms, the phenotype, typically is proportional to the amount of the chromosome that's been deleted, because there are several genes on the chromosome that are important, and an absence of those genes will result in these various symptoms and manifestations. 80 to 85% of cases are the result of a de novo deletion, but 10 to 15% are due to a parental translocation, which results in a monosomy of chromosome 5p. The deleted 5p is paternal in origin in about 80% of cases. Don't really know why that is. Most of the symptoms can be attributed to a relatively small region along 5p15.2. That is going to account for most of your abnormalities, your craniofacial abnormalities, the developmental abnormalities, mental retardation, and so forth. But the cat-like cry is actually associated with a loss of a region in 5p15.3. So there are a very, very small minority of patients, less than 5%, who have all the features of Cri-du-Chat but don't have that characteristic cry. And that would be if you're missing the 15.2 region, but you're not missing that 15.3 region. So when you see that 95.9% of patients with Cri-du-Chat syndrome have the characteristic cry, and you think, well, don't you have to have the characteristic cry to have Cri-du-Chat? It is in its name, after all. This is French for cry of the cat. The answer to that is no. You don't have to have that characteristic cry. But on the test, I guarantee you, if they're asking you about a patient with Cri-du-Chat and that's what they want you to think of, they're going to give you that as part of the vignette. There are various relevant genes. CMAF codes for a protein called semaphorin F. CTNND2 codes for a protein called delta-catenin, and these proteins are important in neurological development. There's also a protein called TERT, which stands for telomere reverse transcriptase, And this is important for the maintenance of telomeres, which, remember, are the ends of the chromosomes that function as sort of a buffer region. And they get shorter as you age, and that's what's behind a lot of the aging process. And what you'll see in Cri-du-Chat patients is that they get premature graying of the hair. And that's probably what's behind that, because hair develops so rapidly during life, and we grow hair all the time. The telomeres shorten and shorten and shorten, and eventually you get gray hair. There are a lot of features in Cri-du-Chat syndrome, and so I put the percentages on some of these that I could find. The ones that I put in red are the ones that are really important to remember. So, of course, the characteristic cry. You can Google it and you can hear it. You will never forget it. It's very obviously abnormal. These babies tend to be low birth weight. They also tend to be hypotonic, and like I said, that transitions to hypertonia in childhood. About a third of these patients will have laryngomalacia, and that contributes to the characteristic cry. But another reason this is a big deal is because when these patients go in for surgery, the anesthesiologist can have a hard time intubating them. Craniofacially, they tend to be microcephalic. They'll track between less than the 5th percentile, usually 3rd percentile, during their infant development as far as head circumference. They tend to have a round face with full cheeks. I'll show you some pictures of those. Usually they have the epicanthal folds that you see some like in Down syndrome. Hypertelorism is a pretty salient feature in Cri-du-Chat. Anti-mongoloid slant, so that's the downward slanting palpebral fissures. They can have prominent supraorbital arches. They tend to have a pretty prominent nose in that it's wider than usual. They can have smaller chins, low-set ears. In childhood, there's some facial laxity, and so a lot of times you'll see these kids walking around with a dropped jaw or open mouth, and then a short philtrum. And as they develop, the features change. Their face develops more to become longer and narrower, and those supraorbital arches can become more prominent with time. Skeletally, about half of them will develop scoliosis. You'll notice a simian crease in the hands on the vast majority of these children. They can have shorter fingers. They have a tendency towards dental malocclusion, and then less commonly, you'll see dislocated hips, club foot, oligosyndactyly, pes planus, and hyperextensible joints. You'll need to screen all of these babies for congenital heart defects with a echocardiogram. Neurodevelopmentally, pretty much all of these children are going to have intellectual disability to some extent. A lot of them will be pretty profound. Speech production disability is pretty uniform across Cri-du-Chat, so these children will not generally be fluent in speech at all. However, they will be able to sign in most cases, and their receptive fluency is much better than their vocal fluency. So you can talk to them. A lot of times they'll understand you. They just won't be able to speak back very well. They can also be a little bit clumsy, and hyperacusis is another feature that is seen in Cri-du-Chat as well. Remember, hyperacusis, we don't see that a lot. It's something you can see in Williams syndrome as well. Behaviorally, they can have problems. Hyperactivity is most common. You can also see tantrums, self-injurious behavior, aggression, repetitive movements. Some of that's due to neurologic issues, and then some of it is due to the intellectual disability and not really being aware of what's socially acceptable and what's not. They do tend to have chronic medical issues. Constipation is probably the most seen, and that leads to another concept behind Cri-du-Chat is a lot of them will have failure to pass meconium. They can have Hirschsprung's disease early on as well. Like I said, there's the premature graying of hair. About half of these babies will have cleft lip or cleft palate. They tend to be short as adults. And then there's some other things that are a little less common, small testes, GU anomalies. You'll want to look at their kidneys as part of their screening, inguinal hernia, malrotation, and thymic dysplasia. So this is just something I found online about some of these symptoms that can come across here. Notice the hypertelorism, the protruding ears, prominent nose, slightly smaller than usual chin on this baby. Here's the simian crease, and then there's some other things that are written down here. So this baby has obviously a cleft lip and very profound hypertelorism, and that also gives rise to that wider nasal base, although you can't really appreciate that too much here because that cleft palate is in the way. You can also see the epicanthal folds. Now the ears look pretty normal to me. You can also probably see that this chin is a little smaller as well. So this child, you can see the low set ears, the nose is a little wider, the eyes are somewhat far apart, but not as far apart as on that baby we just saw, and then you can kind of see the epicanthal folds. The mouth, this sort of frowning face, these children can have sort of a what one would call a permanent frown. Some people are just born with that no matter what. Sometimes people come up to me and say, "Why do you look so sad?" Not. That's just the way my mouth is when I'm not making a face. These children tend to have that. So this baby is probably not sad, but has that sort of frowny face, and that's something that you can see here. So this kid obviously is smiling, but you can see the epicanthal folds here. He's got somewhat arched eyebrows. The ears are protruding laterally, and he does have those nice puffy cheeks that you see in about 80 to 90% of these children. This is a young man as he is grown up. So you can see when he was young, he had relatively large ears. You can definitely see the epicanthal folds. His nose is not too prominent, but you can definitely see as he gets older, it does take on a little bit more prominence, becomes coarser. His ears, well, he kind of grows into his ears, but very early on, his ears are quite large and laterally protruding. He has the epicanthal folds. His teeth are in relatively good shape for Cri-du-Chat syndrome. A lot of times these children will have dental malocclusion, but not all the time. He also, you can see the sort of puffier cheeks here as he's about 4 or 5 years old on this picture. Now this child obviously has some serious malocclusion issues, and you'll see that. She does have puffier cheeks, and that sort of makes her nasolabial folds a little bit more prominent here. She also has the wider nose and the epicanthal folds. Her hair is sort of covering up her ears, but her ears are protruding laterally. Now this child has that characteristic facial leg that comes on a little bit later in life. He's got a particularly significant case of it. You can also see the hypertelorism. His ears are a little bit larger than normal. His nose is pretty prominent as well. And this child has very, very, very significant hypertelorism. And he's also got that sort of mouth hanging open deal. But notice that his ears appear relatively normal. So hopefully you've gathered from this that in any one child you don't see all of the features necessarily. Some children will have some, other children will have others, but the hypertelorism and the nose, those are some of the more common ones that you'll see. And also if you took a circumference of these children's heads, they would be abnormal. And also the epicanthal folds too. Now this girl is a little bit older. It's kind of blurry, but she does have dental malocclusion. Um, she's got the folds up here. Her nose is quite prominent. Of course, you can't see her ears because it's covered with hair. Developmentally, of course, they do have small heads. We mentioned that 3rd to 5th percentile for head circumference. Feeding difficulties are pretty common, and that can lead to failure to thrive, and sometimes that can necessitate the placement of a G-tube temporarily. Cognitively, of course, because there's intellectual disability in virtually all of these patients, that's going to affect their development. Speech production is highly affected, like we said. But the child tends to understand language better than they can produce it. And for this reason, early introduction to sign language is going to be very useful for communication with their caretakers, and they tend to be able to sign pretty good. Socially, pretty much, there's really nothing socially that's wrong with them. It's going to be pretty much affected by their limited cognition, although there are some of those behavioral issues that can be seen. Diagnosis is typically suspected clinically. Usually the obstetrician will note that high-pitched cry, and that will should prompt laboratory investigation. The best initial diagnostic step is just a simple karyotype analysis. A lot of times we'll be able to pick it up on that. If that comes back negative or normal, and there's still suspicious clinical findings, the high-pitched cry, facial features, then that should be followed up by a more accurate test, which you can get fluorescent in situ hybridization. There's also more higher resolution cytogenetic studies that can be done. But the FISH is pretty good for diagnosing this. Other tests should be undertaken as well. Cranial radiographs are good. Some of these kids have cranial base malformations that you'll want to detect. Getting an MRI of the brain is useful, not only for diagnosing any abnormalities there, but also for differentiating this from some of the other syndromes that can look like this in some cases, such as Patau syndrome and Wolff-Hirschhorn syndrome. Echocardiography is going to be mandatory to screen these patients for congenital heart defects. Those need to be managed right away if it's indicated. So things like tetralogy or PDA. And then you'll also want to get, I didn't put it on here, but you also want to get a sonography of their kidneys to make sure that there's no abnormalities there. So our differential includes Patau syndrome. Typically this is associated with older maternal age. You'll see hollow prosencephaly on MRI, but these kids can also have cleft lip and palate. They tend to, whereas you only see that in about half of Cri-du-Chat patients. Single umbilical artery is generally going to be noticed on the placenta, and then these kids tend to have microphthalmia. You usually don't see that in Cri-du-Chat. You'll see abnormalities of the eyes, but mostly in that you have epicanthal folds and that they're far apart. And then Patau syndrome is also associated with midline defects, and this is due to a deletion of the entirety of chromosome 13, or major parts of it. Wolff-Hirschhorn syndrome is strikingly similar to Cri-du-Chat. You'll see pretty much all of the major features that you see in Cri-du-Chat. This is associated with a quote-unquote weak cry. These children also tend to have seizures. There's a much higher mortality with Wolff-Hirschhorn, and the prognosis is much worse. This is due to a deletion of 4p. But what's really going to help you is getting those cytogenetic studies, and you'll be able to differentiate it from that. So it's not so much important differentiating Cri-du-Chat from Wolff-Hirschhorn right away, because the features are so similar, and primarily we're treating this symptomatically. But just keep it in mind that this is another syndrome that looks very similar and presents in a lot of the same ways, but this is different. This is a deletion of 4p. Management. So there's no cure for Cri-du-Chat, as there aren't for a lot of genetic disorders. So the management is going to be focused on screening and prevention, maximizing their development through interventions like through speech-language pathologists and psychology, physical therapy, occupational therapy, and then also attending to their symptoms. So initially, of course, you want to correct any life-threatening conditions such as congenital heart defects if that's necessary, wanting to make sure that you take extra caution with anesthesia because we know that these children tend to have a possible laryngomalacia, which can make intubation difficult. There are cases where there'll be such severe feeding difficulties leading to failure to thrive, which may require G-tube placement. This tends to get better with time. Screening echocardiogram is absolutely mandatory, and that's going to prompt you to get these congenital heart defects fixed. Of course, like I mentioned, getting a sonogram of the abdomen, looking at the kidneys, is good to do as well. You'll want to refer these children to clinical geneticists, and they'll be able to coordinate their care with other specialists. And then last but not least, the parents are going to, of course, ask you with any genetic syndrome, they're going to ask, is this my fault? Did this come from me? What's the odds of me having another baby with the same syndrome? And the answer to that question is, of course, it depends. Most of the time, this is a de novo mutation, and so the parents' chances of having another child with Cri-du-Chat syndrome is 1 in 50,000, as is for everybody else. But if they do happen to be in that 10 to 15% that have a balanced translocation of 5P, then they have a 1 in would be a 1 in 4 chance of having a child with Cri-du-Chat syndrome. And so you'll want them to know that if they're considering future pregnancies, and so you'll send them to a genetic counselor to get cytologic testing. Further management into childhood is going to involve a lot of different professionals, namely physical therapy and occupational therapy, speech-language pathology to maximize their functioning. Typically, they'll need to be seen quite extensively by a dentist because a lot of them have issues with their teeth. And then other professionals can be seen as necessary depending on their manifestations. Like I said, you want to introduce them early to sign language because that's going to be their primary means of communication, at least their ways of verbal/nonverbal communication. Like I said, they can usually receive communication relatively well. And then medical management for chronic conditions, upper respiratory tract infections, otitis media, constipation. All of those things tend to be seen in higher frequency in these children. The overall mortality rate of Cri-du-Chat is 10%, and it typically relates to the complications and the severity, but it's generally going to be very early on. And so if they make it past the first year of life, they tend to be okay. So 75% occur in the first few months of life, 90% occur in the first year of life. Their expressive linguistic skills are going to remain poor throughout their life, but many children are able to communicate through signing, and with extensive and proper therapy, patients can often attain the developmental and social skills of a 5 or 6 year old. They're able to attend to self-care, but they'll need to be, obviously, they can't live independently. They'll need to have a caretaker throughout their life. And you can see this woman with Cri-du-Chat syndrome. Her facial features are a lot more coarse. She has the fullness in the cheeks, which you can sort of see those nasolabial folds here. She's a lot too young to have prominent nasolabial folds just from aging. You can't really see the eye. You can kind of see the epicanthal fold on this left eye here. And then you can see that she's got a little bit of dental malocclusion here. And then she's got that sort of hanging mouth, which is from the facial laxity. So if you have any questions, go ahead and write me a comment below. Otherwise, thank you for watching, and I will see you next time.